with that, I will stop, and then I'll let Mary talk more about the details of the tax.
Thanks. So I'll just quickly go over what the governor's proposal has been since January. As has been mentioned, the existing tax that we have, it's been clearly stated by the federal government, we cannot continue to have the tax, and that we need to either not have a tax at all or have one that meets the federal requirements. And generally those are what I mentioned, that it needs to be broad-based and uniform, and that an individual provider, whether it be a plan or whoever we're taxing, can't be held harmless for the cost of the tax. And so our existing tax, as has been mentioned, only on our Medi-Cal managed care plans, they receive it back, and there's a net general fund savings that's used to fund the Medi-Cal program. The tax that's been proposed by the governor is intended to meet the federal requirements of being broad-based and uniform with no hold harmless. That does mean at the end of the day, there is a net financial impact overall to the health plan industry. That is at about $658 million in the proposal that we've put out. It's a little less than 0.5% of all health plan revenue. The tax that we've put forward, the goals we were looking at, how do we make sure we're collecting the $1.1 billion in order to make sure that there is not a hole in the Medi-Cal budget? How do we have enough funding to offset the reduction of the HSS hours? And really, how do we make sure that the tax is having the least financial impact to the health plan industry as possible while still meeting the federal requirements? And so what we developed was a tax that is based on cumulative enrollment in a health plan on a quarterly basis. So we're moving away from a revenue-based tax. Currently, it's a % of revenue. What we've moved to is an enrollment-based tax. And we've structured it with 5 different tiers where the amount of tax varies depending on your cumulative enrollment. So essentially, everyone for their first, set of members, 100,000 members or whatever, pays a certain amount per member. And then if you have members more than that, for the next level, you pay a different amount for those members, and so on. We structured the tax so that it's smaller at the beginning, then goes up and comes back down. There's 5 different tiers, and I'm happy to talk more about them if you want to know the details. But the reason we structured it that way was we really were trying to hit that sweet spot of how do we meet the federal requirements, raise the money that we're talking about, and have the lowest financial impact. There certainly are other ways we could assess the tax, and certainly we've been in ongoing conversations with our plans and others about other options that would still meet the same goals. But this was the way that we found that sort of met those goals entirely and really tried to keep the total amount of impact to plans at the lowest amount possible. So with that, I will turn it over to Teresa.
Hello, Teresa Calvert with Department of Finance. I think a lot of what I was going to cover has been covered by the previous speakers. And part of that was just kind of a history of the MCO recently, and that it was most recently revised in 2013. I would just add on to what's been stated previously that the tax revenues, the MCO tax revenues now are used for the Medi-Cal program expenditures that includes children, seniors, and persons with disabilities and dual eligibles. But I'm also available for questions as they relate to the budget.
Thank you. So at this time, I believe Senator Nielsen, you had a question, comment?
Just a quick question, if I may, to Deputy Director Doyle. You mentioned a stable ongoing source. What would that mean? What are you referring to? What kind of things would be a stable ongoing source of funding?
Can you, for who is the question? I
believe it's Mr. Doyle who mentioned it. Or Wilkeny, I'm sorry, Mr. Wilkeny. Okay. You mentioned a stable, stable ongoing source of funding. One legislature can't really oblige a future one, although we do COLAs, but we're getting out of the habit of that. But what are you looking at as a stable ongoing source of funding?
An example would be an MCO as we proposed in the January budget.
Yeah, so you'd reauthorize it each year then?
Yeah. Well, yeah, we would look for it to be established without the sunset, but you're right. Any legislature that comes after can change the tax structure.
I'm doing it.
Yeah.
Any other questions from any of the members? Just very quick comment. I appreciate the explanation. And especially how you kind of define the overall budget of Medi-Cal, which is 95 to 96 billion, and only 18 billion of it comes from general fund. And I think the point that is just as important that we need to understand is that the MCO tax is an iteration of previous taxes that have been defined by federal government, where we've used over the years since, I believe you said 2005. And ideally, yes, we'd like to have a continuous sort without a sunset. But I think the biggest change that occurred this year as opposed to last year, and the difficulty, is that we're going to be writing complicated state law to mirror federal law or federal requirements. And the biggest thing and the most difficult thing is there's got to be winners and losers, as opposed to before we'd only tax the plans that saw Medi-Cal and it was a net revenue break even. That's what's going to be difficult. So here's the challenge. Let's say we can't get this done. I get it. If that's the case, then we're going to be short $1.1 billion that we're going to have to make up somewhere else that is going to cut additional sources. So I think that what we need to do is, highest priority, is figure out how we do this. And I know that I've been meeting with the plans. They've been very interested because they realize the importance of making sure this happens. And, you know, perhaps maybe I can just ask the question. I understand the difference between the tiered structure, because the tiered structures brings us the most revenue in, and yes, there's going to be less impact on certain plans. But just if you can kind of talk to me a little difference between the tiered structure and just a flat rate. And I think that might also, because there's going to be a proposal on that as well.
Sure. So yes, as I mentioned, one of the goals we were sort of trying to achieve when we first came up with the proposal was try to have sort of the lowest overall impact. But that is a differential impact across plans. So those plans who have only Medi-Cal business, they are the same as they were under the old proposal. They have no net impact because we do have to build the cost of the tax into their rates. So as I mentioned, a little less than 0.5% is the overall impact across all the health plan industry. But the reality is that the impact goes from 0 to almost 4% of revenue. And so that is sort of the challenge with the structure and having winners and losers. If we did an overall flat tax, it would be, you know, across the board a higher percent impact across the industry. I don't know that number off the top of my head, but I believe it's less than 1%, just a little under 1%. But then it would be that across all plans, and there would not be a differential impact. That, you know, so that is an option, and certainly we have, you know, happy to work with the plans on looking at what that kind of structure would look like. It also could be a revenue tax or different tiers. There really are a multitude of options, and we've worked with the plans before and continue to be happy to work with them and others on what other options there are.
What other options are anticipated? You know, because when I need to look at it, all the different options, what brings in the most revenue to the state, but could perhaps have the least impact on any entity? Are there any other options on the table, or any thought process at all to that?
So at least we couldn't find an option that had a lower overall impact on plans. At the end of the day, the $658 million impact that I mentioned, which does generate, though, a $1.35 billion, funding for the state, so it's not obviously a one-to-one. There was no other structure that still brought in the $1.35 billion and had less of an overall impact. But again, certainly it could bring down the impact on some plans and bring up the impact on others. So there's really any option someone could think of. It could be a possibility as long as it meets the federal rules. And we've looked at all of those different tiers, fewer tiers, tiers based on revenue. But it sort of just depends on sort of at the end of the day, what is the overall goal?
It's incumbent upon us to try to figure out the best revenue, the most revenue, and the least impact to as few plans as possible. And I think that's our fiduciary responsibility. So let's say we go with the tiered. There are going to be some losers. Those losers are the plans that don't see Medi-Cal patients. And I'm assuming, and we need to obviously ask this question, then they would pass those losses on to consumers as well. And if that's the case, then how do we figure out how we least impact that portion of the population as well? I think these are a lot of questions that we need to ask and figure out the answers to. Senator Morlock.
So I think you've summarized that our options are twofold. One is we find a new MCO variant, or we have to find $1.1 billion elsewhere in the general fund. So is that really an option? Or have we foreclosed on looking at cutting anything in the current budget?
Well, what's at the table right now is how do we continue the revenue source that we currently have through the MCO and try to make sure that we don't have to reduce that revenue within the Medi-Cal budget? Because now not only will we have less money coming in, then that affects potentially other programs, and we still have to have that discussion. And I can remember on the floor, the importance of increasing rates, money for disabled, et cetera. So to me, this is right now is the pressing issue is how do we make sure we continue with this current revenue stream?
Okay.
So,
Because I want to cut Senator Mitchell's child care. That's why I'm here. So that's where I'm going to find the $1 billion.
I hope you're kidding.
That's why I'm not sitting over there, Mr. Chair.
I believe Senator Morrell and then Senator Leno.
Yes, thank you very much. One just quick question. Has the DHCS produced a document actually detailing the proceeds, itemizing them of the existing tax and how and where they've been spent? Is there something that you have that you can deliver to us?
So just so I can clarify the question, so how we use the existing tax to fund the program, is that what you're asking? Sure.
Do you have those itemized, the existing funds that came through the proceeds that you can
Yes, we
give
could
to us
absolutely provide that
so we know
to you.
how that's being spent?
Absolutely.
Thank you very much.
Sure.
Senator Leno and then Senator Pan.
Thank you, Mr. Chair, and thank you for reiterating that what we're talking about is just sustaining the status quo. This is not about finding money for the restoration of the cuts we've made for reimbursement rates. It's just to hold on to the status quo, and it's the $1.1 billion, as you mentioned, but it's also, as was mentioned by the Undersecretary in his presentation, it's also the little more than $200 million for IHSS. We need additional funding in out years for that. So we're really talking about $1.3 billion hit if we're not able to resolve this. And I think it's important for us to keep in mind, keep a perspective on the size relative to the overall Medi-Cal program. And Ms. Cantwell, I think you did a good job of pointing that out, that 0.5 percentage point of our overall Medi-Cal budget. Is that accurately described?
It's 0.5 percentage point of all health plan revenue, so I wasn't doing it as
Thank you.
Yes,
That's
sure.
better. Thank you. Thank you for correcting me. Health plan revenues, 0.5%. So it's never easy for any of us, even for those from San Francisco, to go back home and have to talk about new revenue that may impact a constituent's pocketbook. That's not a pleasant conversation. But when we're keeping it in a perspective of 0.5 percentage point, now that would be if it were flat. If we're going to tier, some are going to be more than that, some less. But though as important as this $1.3 billion is to us in our general fund, relative to the entire revenue source that comes from the plans, it's 0.5 percentage point. So if it were flat, and this is a question for Ms. Cantwell, if it were flat, whether it's 0.5% or 1%, is it accurate to extrapolate that the average plan, again, if it were flat, so we can just compare apples and apples here, that a premium might go up 0.5 or 1%? Would it be about the same if it got passed on? And the reason I ask that is that we still see some plans increasing their rates, whether appropriately due to costs, and sometimes there's information we see that it's just for additional profits, going up 10, 15, 20% a year. So if we're talking about 0.5% or 1% for the purpose of the benefit of the general good, the commonwealth, the commonweal, benefiting across the board, this is a rounding error. Am I anywhere close here?
So certainly, I mean, I think from obviously what we know when we set Medi-Cal managed care plan rates is we have to build the cost of the tax into the essentially their premiums that we're paying them. And so certainly it is typical actuarial practice that I am certain would happen on a commercial plan side, that they would have to consider the cost of the tax as they were trying to determine what premiums they were going to charge employers or individuals.
And again, is that extrapolation accurate, or is that way off? It wouldn't be in that neighborhood?
Oh, yes. No, I mean, I think the cost, if the cost of the, yes, I mean, I think if we're talking about generally something that was a 1% cost, it would be reasonable to assume a 1%.
Would get passed on.
That is exactly how we do it on the Medi-Cal side. When we've done, you know, right now the tax is a 3.9375% revenue tax. We add that to the Medi-Cal managed care rates.
And I'm not sure that you would have this figure, but if we're talking about the plans that don't serve Medi-Cal beneficiaries, on average, what kind of premium increases have we seen over the past 3-5 years or so?
So I don't actually know that, since I'm not the Department of Financial Health Care, but certainly, you know, I think we as an agency could find that out and provide that to you.
That would probably be helpful for all of us. Thank you. Thank you, Mr. Chair.
Thank you. Senator Pan?
Oh, thank you so very much. So because we're talking a lot about the 1.1 billion, but so I just want to clarify, that's the general fund hit. But as I mentioned earlier in my opening remarks, the actual impact on Medi-Cal and the state of California and all the people who are part of the Medi-Cal system, actually twice that, right, because of matching funds. So we're not talking about 1.1 billion cut if we can't fill this hole. We're talking about 2.2 billion cut. It's a 1.1 billion hole of general fund revenue, but it's a $2.2 billion hit loss to the Medi-Cal program and to the healthcare system. Correct?
That's accurate, Senator.
Okay, and then and then of course certainly also for IHSS we have a similar situation. It's a 226 million on state immediately, but actually on the IHSS system, it's double that. So it's almost $500 million, actually over $500 million, correct?
Just a little under, but yeah.
Yeah. Okay. Yeah, a little under. Yeah, almost.
It's with county funds. It's probably a little. It's over.
Right. Okay. So I mean, I think we need to keep that in mind. That's economic. And again, that's about jobs. That's about economic impact and ripple effects and so forth. And actually, frankly, I don't think those healthcare needs go away. And while some people will defer them, they will eventually show up and be borne by premium payers as people have to negotiate with hospitals and others. And if there's a hole there, depending on, well, I guess we're already doing that in Medi-Cal because we're underpaying. But that's going to certainly be a challenge, right?
What it would do, Senator, is it would set up a conversation about where we would find that, because we'd have to figure out where to do the reductions to provide that funding. So it would lead into a discussion about prioritization in the budget, and so it wouldn't necessarily come directly out of these for the 7% IHSS hours. We would still have the restoration in all likelihood, though we would have to have a discussion then about do we take a reduction in IHSS or do you take a reduction somewhere else in the budget to make up for that?
Right. But certainly it's $1 billion of California taxpayer dollars that went to Washington that we could have brought back that we gave up.
Right.
More than that. Okay. And then the other thing in terms of, I know we're looking at different options in regards to the MCO tax. I mean, I think one of the things hopefully we can get that to try to keep in mind as well is that, well, certainly we're talking about the overall impact on the health plans. We also need to recognize each health plan is an entity unto itself. I think one of the challenges we're going to have to navigate, I appreciate what the governor's proposed with the tiered system, but you're also running into issues around competitiveness. So if you're a plan and you're at the higher tier and you're competing against, so this is not even simply about, do I just raise my rates? The problem is I'm raising my rates to make up for this tax, but someone else, at a different tier, doesn't have to raise their rates as much, and I'm competing in the same marketplace for people and say, hey, pay more premiums for my plan than that other plan. So I think we need to figure out how to navigate that piece. So while we can say collectively we're trying to minimize, I think we also need to look at what this is doing to the marketplace and how this may advantage or disadvantage individual plans, and how that dynamic may make it, may create some challenges there. Recognizing, given the new federal rules, how we navigate that. But I think we do need to be sensitive to that, and in terms of that dynamic, and really trying to figure out what's the overall playing field. In addition, I guess the other question is that, and you may not have the number right now, out of the sort of the entire healthcare market and the plans, what percentage revenue-wise is Medi-Cal and sort of the managed care market versus versus commercial and so forth? What percentage of the overall market are we financially?
So I don't have that number off the top of my head, but we can certainly provide that. I mean, I think we're close to now about 50 or $60 billion for Medi-Cal managed care, but I don't know the overall headcount, so we'll get back to you on that.
I mean, certainly we know in terms of numbers of people, right? Where Medi-Cal is, it's not all managed care, but we're 30% of adults, about half, actually maybe even over half of children. So, I mean, it's not. Yeah, so it's not, I mean, a lot of people are getting affected. That's certainly the most important. But since we have been talking about money, probably also what the market share is, I think may be an important part of being able to figure out the conversation. Thank you.
Senator Mining, and then Senator Morlock.
Thank you, Mr. Chair. And I want to thank all of those helping us work through this. So my understanding from the comments, the change in the federal requirement is not selective tax, but broad-based tax, all providers. So in the information that we've been provided, it will set up a situation of so-called winners and losers, some who pay the tax but won't necessarily be eligible for regaining that, recouping that, or being eligible for the federal contribution. But when you look at the broader economics of that tax being critical, as Dr. Pan said and others have illustrated, to leveraging the federal dollars, on balance, achieving that federal contribution will inure to the benefit of hospitals, clinics, private providers, all of whom, depending on the services they provide, may be eligible for that support. Is that correct?
Right, through managed care, it's, Medi-Cal is a web, right? It is a complex web of providers and relationships and contracts and funding sources. And so to the extent that the plans are financing hospitals and long-term care facilities and providers, it is a very interwoven area. I would like to just point out and remind the committee that we have a hospital provider tax in place in this state, as well as a nursing home provider tax. So those, in addition, support those types of facilities, but then on top of those taxes to those types of facilities, managed care comes in and contracts with those providers and pays them on a rate that could be or not related at all to the fee-for-service rate. So you have these two-track payment systems in Medi-Cal as well. So through our managed care contracts, through our managed care population, those funds flow in a very different way on a plan-by-plan basis based on how they contract in their local areas, as well as, what you're probably more familiar with is the fee-for-service system, which is a lot. Everyone knows what those rates are because we have those clearly established. Plans pay rates depending on the area that they're located in and the type of contracting that they have available.
Well, thank you. Well, you described that web of our healthcare system of multiple delivery systems. At the core of this is trying to maximize the delivery of healthcare services under the ACA with more eligible covered members, more in prevention, immunizations, tobacco cessation, et cetera, which in the long term reduce our health costs and, more importantly, establish a healthier population. But again, the beneficiaries of the combined tax leveraging the federal income, that is supporting providers, nurses, administrators, the overhead necessary to provide these medical services are dependent in the current formula for those revenues coming from the federal government. Is that accurate?
Yeah. Yes.
And if we fail to secure that continued federal contribution, we go in a hole, not just the $1 billion plus represented by the tax, but what that leverages from the Fed. So we go into a $2 billion plus hole from the status quo. Is that an accurate framing?
That's correct.
Thank you.
Senator Morlock?
Thank you, Mr. Chair. Since we're discussing so many fun, complex issues like fee-for-service and capitation rates and all the fun stuff that goes with this industry, I'm just curious, do we have industry benchmarks that tell us what managed care organizations are generating as far as gross profit margins? Is it 6%? Is it 2%? Is it 20%?
I think, we can speak to what we monitor on our Medi-Cal plans. So the Department of Managed Healthcare obviously regulates and oversees the vast majority of the health plan market in California. We have plans that sit in both the Department of Managed Healthcare as well as with us in terms of oversight and regulatory responsibilities. Through our contracts, and we publicly have shared this information on our plans, the financial health. We monitor the financial health of our plans on a regular basis. Our rates reflect actuarially sound capitation rates. So we have an actuarial firm that will sign off, and the federal government requires us to have an actuary signing off on our rates, and then they approve them through the federal side, and they're now sending them through the Office of the Actuary on the federal side. So the rates on the capitated side are generally held to be pretty, they're on a pretty responsible level, I would say, in terms of our medical loss ratios on our plans. We're normally seeing somewhere up in the 90 percentile, 90 to 95, which the commercial MLR requirements according to the ACA are 85%. So we have plans in Medi-Cal that have a slightly higher MLR, which means 90% of the funds that they are receiving are going directly into medical services as opposed to admin overhead profit. So we feel that we pretty closely monitor and see a very tight rate on the Medi-Cal side, but that doesn't necessarily speak to what we see, or because we don't monitor the commercial side, and there's not like an industry standard. It's really on a plan-by-plan basis, and so to the extent that we have plans that are experiencing higher than normal rate losses, in terms of if we have a plan that is, we've had plans that have had really difficult populations that were higher costs than what we would have otherwise projected. We have done things in extraordinary times to make sure that they receive an adjustment to kind of help settle that out, because some plans obviously would have a slightly healthier population. It really on a case-by-case basis, it depends.
Well, just from observing the hospitals and the healthcare industry in my county, I get the sense that their gross profit margins aren't that high, maybe 2, 3, 4%. And so then when the state says to providers, and the chair might be able to help me, but we're going to cut your provider rates by 10%, and then the next year it's another 10%. I get the sense that they don't have the reserves to handle that. So now the doctors, the employees of those managed care organizations then have to take pay cuts so they can stay within a profit mode. So I only bring that up because when we start talking real numbers like $2 billion as opposed to, well, it's only 0.5%. Well, 0.5% for a managed care organization could be half of their net profits. So I just want to be careful how we use terminology. I'm also curious if you happen to know what CalPERS is looking at in the way of increasing their rates for insurance. I saw an article, but I failed to memorize the number, but I thought it was above 5% for next year. Is that correct?
Not sure. We could check into that for you.
Okay, so we're already seeing the impacts, and that'll affect then state employees and our budget. So all these things are interrelated. So I like your use of the word web. I mean, it gets to be quite interesting how all this gets to be a nice Rubik's Cube. So thank you, Mr. Chair.